Bonjour, everyone. Good afternoon, everyone. I'm Linda Silas. I'm National President for the Canadian Federation of Nurses Union, and I'd like to welcome you to our webinar today on Canada Beyond COVID-19, Looking Back to Move Forward. Bonjour, je suis Linda Silas. La session va se dérouler en anglais, mais nous avons un service de traduction simultanée. Alors, si vous regardez au bas de l'écran, vous allez pouvoir cliquer sur le drapeau anglais ou français. Si que vous cliquez en français, bien entendu, toute la traduction va se faire. Et en anglais, c'est pour entendre nos conférenciers en anglais. Aussi, vos questions, toutes dans la boîte en chat, vous pouvez les poser en français. Si vous voulez, je ferai la traduction. I just explained that our session will be in English only, but we have a translation services, which is just at the bottom of your screen. You either click in English or in French. If you click in French, all of what you will hear will be in French. If you click in English, it'll all be in English, of course. The chat box is for your questions. You can ask them in French or in English, and we'll move forward. So now let's start. As we know, in Canada, we have over 70,000 Canadians that are infected with COVID-19. We have over 5,000 deaths with this viral virus, and 80% of them are in our long-term care sector. We also know that between 11 and 24%, it depends on the province, the areas of work, healthcare workers are infected with the COVID-19, mostly when they're at work. We know that we've sadly lost many long-term care workers in Canada. It's about 10, maybe more. We have a lot of problem in getting that data, and we'll talk about that later. Yesterday, we lost our first RN to COVID-19. Many, many more essential workers have also lost their lives, and we can't forget them. Many have passed away due to COVID-19 for going into work. We're talking about grocery store workers, airport workers, taxi drivers, and most recently, workers that work in meat plants. We think about them and their family. Today, Vicky McKenna and I are reigniting a campaign of nurses unions that we've had for a couple of years, Wear White Wednesday, and it is to think and send our best condolences to Brian Beatty's family, the RN that passed away yesterday. He lost his life fighting against COVID-19, and he lost his life caring for his other family, which was his long-term care family in London, Ontario. So all nurses, we will be wearing Wear White on Wednesdays from now on, once again. In the previous years, CFNU have always hosted a parliamentary breakfast, and right now we have to do everything virtually, as you know. So this lunch on the Hill is virtually. I'm sorry we can't host you and can't have the parliamentary restaurant with their beautiful food for you, but it will come back, I promise. It will be a better day one day. We'll all be gathering on the Hill to discuss face-to-face with our parliamentarian what's happening in healthcare. We have over 100 participants on this webinar, which will also be posted on our YouTube channel and on our Facebook, so many more will be able to hear these experts. We have around 30 MPs and senators. I'll just name those who are members of the ESSA committee and the UMA committee, which are the two committees we deal more on healthcare. We have MP or Mr. Davies. We have Ms. Jensen, Mr. Generou, Ms. Kuzi, Ms. Sindhu, Monsieur Theriault, and several senators too. And I do thank you for being here. To all of you and to our speakers, we know it's difficult times, and I thank you for your time. What CFNU will be doing is we're giving a donation to the Food Bank of Canada, which is the cost of hosting one of these breakfasts. So we'll be donating $10,000. Plus, in the name of our 4 speakers, we're donating $1,000 for each of you for saying thank you and for your time here. So now let me start with our first speaker. Our first speaker comes with all his experience on SARS in 2003 and then the report in 2005. It's Mario Pasai. He's an expert in occupational health and safety and a former senior advisor to SARS, led by Justice Archie Campbell. Mario, please.
Linda, thank you very much for that warm introduction, and good afternoon, everyone. And let me extend my condolences to the families of the victims of COVID-19. SARS was a dress rehearsal for COVID-19. It offered important lessons for pandemic planning and containment. Some countries deeply affected by SARS learned its lessons. Others did not. Sadly, Canada is among the latter. First, some quick facts about SARS. Like COVID, SARS was caused by coronavirus. It likely came from a bat reservoir. China and Hong Kong were most affected by SARS. This will be important to keep in mind when we look at lessons learned from SARS. And Ontario was the North American epicenter. An important feature of SARS, both here in Ontario and in China and Hong Kong, was that healthcare workers comprised a significant proportion of SARS cases. In the wake of the outbreak, Justice Archie Campbell was appointed to, in June of 2003, to investigate the outbreak. And it's important to keep in mind that it was structured to be like an accident safety investigation. There were no findings of civil or criminal responsibility. The idea was really to get at and identify and learn from the root causes. There were many important lessons from SARS. One of the most important was the shortages of personal protective equipment, which was identified in a survey of Union of Nurses in 2003. And Justice Campbell pointed out the importance of having a secure supply chain should a future outbreak happen, including a pandemic. Ontario went ahead and did that. They established an emergency stockpile in 2007, but sadly and tragically, in fact, the stockpile was destroyed, frittered away, and sadly is not available for our health workers today. Federally as well, with the Canadian pandemic plan, there was a recognition that we had to have a strategic supply. And despite this, as we entered into the pandemic, the federal stockpile had only 100,095 respirators. And just for your information, the province of Ontario goes through about 350,000 N95s in a week, only for high-risk operations or procedures, as opposed to looking after all healthcare workers. Another area that was identified by during SARS was issues with lab testing capacity. And Justice Campbell made some significant recommendations in this area. But as we've seen here in Ontario, we weren't ready. And sadly, our lab testing capacity has not been up to where it should have been. The core recommendation of the SARS Commission was that action to reduce risk need not await scientific certainty. That's known as the precautionary principle. And it arose from a debate during SARS that was very similar to what's going on today with regards to COVID and worker safety protections. Some medical leaders felt that SARS was not spread through the air. It was only spread by large droplets. And they felt that surgical masks were enough to protect healthcare workers. But worker safety experts said, the science is not settled. They recommended treating SARS as if it was airborne. And 2 years later, after SARS, evidence came out that in fact SARS was airborne. And this demonstrated that being prudent, being precautionary is effective when you have a new disease like SARS. And when we look at China and Hong Kong during COVID, it's clear that they learned from SARS. They take a precautionary approach to protecting their workers. They wear N95 respirators. Amazingly, China sent 42,000 health workers to Wuhan at the height of the outbreak. None was infected. All wore N95s. In Hong Kong, no health worker has been infected. All wear N95s. And the photo on the slide is what healthcare workers in China wear. Compare that to what we're asking our health workers to wear, simple gown, surgical mask. And that's because our federal and provincial public health officials have ruled out airborne transmission. And they did this despite the experience of China in protecting its workers and the fact that there is a lot of evidence coming out suggesting the possibility of airborne transmission. And as we look at the performance of Canada and China and Hong Kong, we'll see that rates of infection among healthcare workers are really tragic and unfortunate in Canada. China, for example, its rates of 4.4% of healthcare workers comprising the total number of cases is mostly comprised of cases early in the outbreak. Since they went to airborne precautions in late January, there have been almost no infections among healthcare workers. And as you can see, if healthcare workers are protected, the ability of a country to contain COVID is also really enhanced. As you can see, we have now surpassed the total number of deaths of China. Our number of cases is getting close to China's, and it's a tragic consequence of us not listening and learning from SARS. Justice Campbell, in completing the SARS Commission, he said that the health and safety of healthcare workers is paramount in a public health emergency. And sadly, we've not heeded those lessons. Thank you. I'll turn that over back to Linda.
Thank you so much, Mario. And for the audience, Mario is one of these experts that continues to guide us in all our discussions, regardless if it's developing union policies or comments to the media. And I thank you for all that expertise. I did an interview this morning and the reporter asked, are healthcare workers, nurses fearful? I said, we've passed the stage of being fear. We're mad. And when we listen to information like this, there's much reason to get mad. So my second speaker tonight, this afternoon, is Dr. Samir Sinha. He's one of the strongest advocates on the needs of seniors. If you watch CBC at all, he's always one of their experts there. He's also, in his spare time, he's a physician and a director of geriatric at Mount Sinai and University Health Network Hospital in Toronto. And he's here to give us an overview of what he thinks is happening in long-term care. Samir, please. There.
Okay, sorry about that.
Thank you.
And great to be here. And so I'm just going to show my slides here and just walk you through a little bit about my perspectives, especially as a geriatrician specializing in the care of older adults, and more specifically, I wanted to share a little bit about what we've seen in Canada's long-term care homes as well. I wanted to really talk about our Canadian experience to date, and really one is what I'm calling a tale of two pandemics, if you will, because we've had a great story about how, despite having, as Mario was just sharing, 68,000 cases to date, we haven't had the rates of deaths that we've seen in other countries, partly because we've done a really good job with physical distancing and our lockdowns across Canada, but we've really seen a real sad story where Canada's taken a leadership in an unfortunate role of leadership in having the highest proportion of its deaths being in our long-term care homes, and that's why I call my short presentation today a tale of two pandemics. I'm the Director of Health Policy Research at the National Institute on Aging, and we're really guided by work that CFNU has proudly sponsored. Really, we're talking about our National Senior Strategy. Canada doesn't have a national senior strategy, even though older Canadians have started outnumbering younger Canadians for the last number of years. But CFNU's support has supported our NIA and many other organizations across the country to advocate for a national senior strategy. And one of those 4 pillars of activity is really trying to strengthen our ability to provide good care that is closer to our homes. One of the things that we've done is we've been investigating the issues in long-term care for a number of years now. But in 2019, the NIA launched a policy series called our Future of Long-Term Care series, and this is really a large piece of work sponsored by many folks and with CFNU and others' participation, where we really want to explore kind of how are we providing long-term care across Canada and place it within the global context of things. We also want to look at what our current challenges are, and there are many, and then also thinking about how do we look to the future? What are the evidence-informed opportunities that really can enable that work moving forward? And I have the links on these slides that I'm sure will be shared so that people can take a look at some of this work as well. And the reason why long-term care matters is it's actually the largest form of hands-on care, primarily provided by nurses and personal support workers, that's actually not covered under the Canada Health Act. So it's a large form of care that really leaves it up to the provinces and territories to organize it as they see fit, because they're not mandated to provide it. And therefore, we see a huge varying degree in which we're actually providing these services across the country. And the challenge is that we're not necessarily providing it in a way that allows us to actually meet the current needs of our aging population. And the system, as we note, has been plagued by long-standing systemic vulnerabilities when it comes to our health, human resources, and physical surroundings in terms of how we organize our long-term care services. And so really when we talk about the story of COVID-19, I want to just really focus, Mario really kind of gave us a story of Canada, and I want to hone in on the Ontario example in particular. And this is just a little timeline that was released by the ministry. It's a little bit dated now, but it just shows, it reminds us how quickly pandemics arrive and how quickly they move. So above the line, you actually see the actions that Ontario was taking in terms of making certain declarations. And what you see below is kind of the story of COVID as it relates to when we started seeing deaths in our long-term care homes, for example. And that was really March 24th. So literally less than 6 weeks ago when we had our very first deaths in our long-term care homes in Ontario. This is just a quick slide showing kind of where Ontario, which is the light blue line, stands with Canada versus Quebec, BC, and Alberta. And you can see even at a provincial and territorial level, in the 4 most affected provinces, you can see that we've had different kind of epidemic curves. And you see how we pair up with places like South Korea, Italy, and that. And so overall, Canada's story has been a better story than some other international jurisdictions. And really, when we talked about flattening the curve, this was the concern that was really, the #1 concern for Ontario planners, was thinking about our hospitals and thinking about SARS and thinking about our ICU bed capacity, and our concern that we would actually see that green line overall as our worst case scenario, an Italian scenario, our blue line being a South Korean best case scenario. But the purple there up until April 19th, which has kind of stayed the same, really shows us the success story that we've had in Ontario and Canada, that our hospitals were fortunately not overwhelmed, our ICUs weren't overwhelmed, the way that we assumed that it might actually be. But the real sad story in Ontario and across the country has really been the fact that we are actually seeing what's been happening in terms of cases amongst residents, and this is just data up until April 18th. So this just shows what we had in terms of residents who are living in long-term care homes. And just to give you a concept, for example, we think about nursing, or what we call long-term care homes in Ontario. There are 626 of those. There are 770 licensed retirement homes. So we have 1,396 nursing and retirement homes that are staffed by nurses and personal support workers. They're fundamentally organized a little bit different in terms of how care is funded and organized. But the point is, this was just the data from the nursing homes in Ontario. And you see already, we started seeing these curves in terms of residents being infected, staff, like our nurses and personal support workers, being infected, and then deaths. At that time, just amongst residents. And now, unfortunately, as Linda shared the news yesterday, we saw our first nurse in a long-term care home pass away. And we've actually had 4, I believe, other personal support workers who've also passed away. So this is where we stand internationally, and I think it really builds upon what Mario was just sharing, because he told you the story about Singapore and Hong Kong. Those are the ones farthest to the right, where you literally see only 4 or 18 deaths in total occurring in their nursing and retirement homes. And I'm actually a consultant for the government of Singapore in terms of working with its nursing and home care services as well. And you can see they learned a lot of lessons that we heard about that were not only reflected in their hospitals and their society, but also in their homes. But you see where Canada actually stands as well here, where actually 78, and actually our latest data through the NIA is 82% of our deaths in Canada have occurred in these homes, and really that makes us an international leader. So my bottom lines are that Canada's response has been variable. Every province and territory has acted differently at different time points. And by doing these things that we've recommended, like stopping non-essential visits, preventing staff working in multiple settings, masking all staff and visitors, implementing infection and prevention and control policies, and not treating this like influenza, but like COVID-19, and by creating more flexible and admission discharge policies. In our report that you can find on our website, it shows us how BC was the most decisive province, and other provinces like Nova Scotia were weeks behind those. And if you want to find the challenge here, is one of the challenges, we're not really being very transparent about the data. So people are finding it hard to figure out where these infections are happening, what the rates of cases and deaths are. Our NIA is now actually, as of tomorrow, going to be lighting up all of Canada so that our frontline workers can be honored with accurate information, as can families and residents, and local hospitals and the Army that are trying to help out. Because we need more radical transparency in a pandemic. It actually helps us help each other, and it helps us stay ahead of the curve. And that's why I'm proud that the NIA has taken leadership. But clearly, I'm hopefully pointing out that in a pandemic, we need to act quickly. We need to act fast. We need to apply the precautionary principle, as Mario said, and we need to be radically transparent so we can best support ourselves and each other. So I think that was my last slide. So my lessons to date: COVID-19 is here to stay for at least 18 months. We need to do better to protect staff and residents, as too many are still facing unnecessary outbreaks, illness, and death. Actions have been encouraging, but we still need to do more. And we need to ensure that we use this as an opportunity to change Canada's long-term care system for better once and for all. And I'm thrilled that CFNU and others like SEIU are trying to lead that conversation as well. So we make sure that we don't just get through this pandemic, but we actually have some really good that comes out of the unfortunate deaths and cases that have happened to date. So I'm going to turn it back over to you, Linda, if that's okay.
Yes. Thank you so much, Samir. Excellent presentation. And, you know, when you said we're leaders in this pandemic, it's hard to, that's not where we want to be leaders in deaths in long-term care. And when you showed your graph about around April 13, where everything really started going up from Quebec, Ontario, BC had a little bit before, and now Nova Scotia. It is sad. So thank you for your presentation, and we'll talk. There's numerous questions coming, so I'm quite excited to go there. My next speaker is a great activist, a good friend. Charlene Stewart is the president of SEIU Healthcare. She's a proud Saskatchewan girl who lives in Ontario right now and travels the country and the world in her job. She represents over 60,000 healthcare workers in Ontario, which are healthcare workers in hospitals, home care, nursing home, and retirement home. And Charlene and I, that Friday evening, when the first personal care worker passed away in Canada, which happened to be one of your members, it was so hard for every union leader, because we heard on CBC that we lost a healthcare worker due to COVID, but we didn't know who. and where and how. And we were all texting each other, and then Charlene confirmed that it was one of her members. So we've been thinking about you, been working with you, and now you're going to give us your expertise on how to fix this mess, Charlene.
Here we go, Linda. Merci. Thank you for inviting me to participate, and thank you for all you are doing to stand up for the hardworking women and men in healthcare right across our country. I'd like to also thank Dr. Sinha, who on Doctors' Day used his platform and position to recognize all healthcare workers, especially those in long-term care. We cannot work in silos. We are one team. So thank you, Dr. Sinha, for speaking up when we need you. I would also like to take a moment to offer my condolences to Canada's family of nurses and the immediate family of Brian Beattie, who, as you mentioned, Linda, we just learned he died yesterday of COVID-19 as well. My deepest regards and sympathies go to the nurses from SEIU, to Vicky and Ona on the loss of their dear member. As you said, we've experienced this 3 times, and it is very heartbreaking. This moment is a tragic reminder that our fight for the safety and security of all workers is not over. That's why it's so important to have conversations like these. Thank you for hearing from me today. But more importantly, thank you for the opportunity to hear from SEIU. As you said, our union represents over 2 million members across the United States, Puerto Rico, and Canada. So we're hearing firsthand some of the stories going on in the United States as well. I proudly serve as International Vice President as well as President of SEIU Healthcare, which represents over 60,000 frontline healthcare workers in the province of Ontario. And many of those members are employed in long-term care facilities, which have become an epicenter for the COVID-19 pandemic. The crushing impact on these homes, their staff, and the residents that they care for cannot be overstated. Simply put, our system of care has failed. Earlier this week, I spoke to the Standing Committee on Government Operations and Estimates, and I want to tell you a few things I told those parliamentarians. They are that we knew 2 things early on. 1, that the virus was severely contagious, and 2, that the elderly were especially susceptible to illness and death. You would think that subnational governments responsible for congregate care settings of the elderly would have immediately recognized the risk of inaction around the long-term care sector. But unfortunately, provinces like Ontario overlooked the privately run long-term care sector and the inherent vulnerabilities that underpin those facilities. And in black and white, the data tells us that these outbreaks and the resulting death toll appear to be concentrated in for-profit facilities. Behind each COVID-19 number is a tragic story. Many frontline workers have died, and most of those have been women, and many were people of color. If we are finally willing to recognize them as healthcare heroes, then I submit to you that it would be an injustice to the families in mourning if we did not examine the failure of our system. First, Canada must obtain and maintain an ongoing supply of personal protective equipment. There's a chorus of cries from our nurses, our personal support workers, dietary aides, cleaners, you name the job classifications, and they will tell you there is rationing of personal protective equipment. Workers who should have been supplied much earlier continue to be left without the appropriate masks, shields, and gowns, leaving them to wear garbage bags instead. And second, out of concern for public health, employment in long-term facilities should and must require full-time jobs with benefits and a pension. Then we wouldn't treat workers as wrongdoing pollinators and restrict them to one facility, as if they had done something wrong, other than just to seek a livable paycheck. And third, we have to mandate higher staffing levels to improve quality of care for residents and seniors. Requiring higher levels of frontline staff would ensure that we have the human resources available to bathe, change, feed, and care for our elderly, not just in a pandemic, but always. The failings we experience today were made worse because for-profit long-term care corporations have a competing self-interest at their core, and that is the fiduciary duty to shareholders. For-profit operations in our long-term care system must come to an end. In a time of crisis, union like ours should not have to resort to the Ontario Labour Relations Board or a court to simply have or get governments to force governments and employers to keep workers safe. In whatever form an overhaul might take, provincial and federal governments must play a role in supporting these precariously employed women who deliver our care. Without that support, the home care and long-term care sectors will leave behind workers incentivized to seek employment in other parts of our healthcare system that provide a more secure retirement, benefits, and full-time jobs. But before I end, I do want to point out the big elephant in the room. If it hasn't already begun, members of Parliament and their colleagues across government are going to continue to be heavily lobbied by massive for-profit long-term care corporations and their industry associations. Companies like Chartwell, Revera, Sienna, and Extendicare will continue to push for government to pay for expenses the company itself should be paying. So when the lobbyists for the for-profit providers knock on your door, I want you to remember all those who have died and ask yourself, whose side will you be on? In my final minute, I want to close with this. The time for a public inquiry is now. This means addressing the crisis today while commissioning the work needed to reveal the failures that left so many people sick, without care, or without life. The SARS Commission, 44 deaths, and there was an inquiry. We are up to 1,700 in Ontario. Should we have consecutive waves of COVID-19 in the fall or winter of next year, we must prepare to avoid today's mistakes. Because as the title of today's event tells us, only by looking back can we move forward. Thank you, Linda.
Thank you, Shirley. And these inquiries, these injunctions, these commission will happen, and we will all work together to make sure we find justice. Like you said, not only for those who have passed, but to protect our generations of healthcare workers. And it has to start today, and we will. My final speaker today is one that knows that working in silo doesn't work, especially in healthcare, but also in our labor movement. Vicki McKenna is a registered nurse, and she's the president of the Ontario Nurses Association, which is, in our world of nursing, the largest nurses union in North America. So as being the largest, we're always very proud to have her at our table, but to share the expertise of ONA's leadership, but also ONA staff, especially in these crises. So Vicki, thank you very much, especially after yesterday. You had to do what any good nurse does, shake it off and get in front of the camera and do your presentation, but no, we're thinking of you. So I'll let you do your presentation, and un gros merci.
Thank you very much, Linda. And I appreciate the opportunity to be able to bring forward to all of you some of the actions that we've taken, but some of the reality out there in Ontario for nurses in this province. And two, I want to acknowledge healthcare workers, certainly, but residents, patients, clients that are ill with COVID-19. Some recovered, but some unfortunately not. And yesterday, as Linda said, is a really tough day. I will say too, of the numbers of people that are hospitalized and in ICUs in Ontario, a number of those are healthcare workers, including nurses. And I am only, praying, hoping that they recover and that we do get through this, but we will see. But it is our job. It is our job to do the very best we can to protect them and to protect all workers, nurses, and health professionals. And when we do that, we keep our residents and patients and clients safe. And I think that is a big piece of what seems to be missing in some of the conversations and logic discussions, or lack thereof logic, that I'm having at various tables, and forgetting what is really important, which is for us Ontarians and Canadians right across this country. So I want to talk about our SARS experience and about the things that we learned. And on the screen, and Julian, if you can go to the first slide, I've included a quote from 2003, the SARS Commission, which we've heard a little bit about already, but it does strike home to certainly the nurses that I represent and health professionals, and the stories of the outbreaks and what it really is about. And it is about those stories and where the gaps were, where the problems are, what is going on, and why we keep failing to recognize what the history of SARS and why it's so important to look back and learn and move forward instead of repeating the same mistakes. But what's happening out there, these are the things that we're seeing there. Every hospital, every government agency, the problems, the communication problems, preparation and planning, accountability, who's supposed to be doing what, worker safety issues, systems problems with infection control, basic infection control principles that people seem to fail to understand, or particularly we're seeing this predominantly in long-term care in particular. And that is around organizations' understandings and administrators' understandings of infection control principles, surveillance, independent safety inspections, and the value of that. And of course, the resources, the people, the systems, follow the money and watch to see where the money's going and where the investments are, and the precautionary principle and the action to reduce risk, and why it's so important to err on the side of caution. And those are the things that we're focusing on and pushing forward. And it's Nursing Week, and it's important, of course, to recognize the role of nurses, and this is an annual recognition, but this year it feels a whole lot different. And it feels a lot different for a number of reasons, certainly COVID-19, but the pressure that everyone is under. And people have said to me, could we just pause it and move on, please, and we'll deal with that later? Because nurses in particular and healthcare professionals are so focused on the patients that they're caring for. And it's difficult to step back from that and to celebrate or acknowledge, but it is still important. And so for just a little bit of context, and Julian, if you can go to the next slide, please. The Ontario Nurses Association, we represent more than 68,000 registered nurses and health professionals here in this province, including respiratory therapists, social workers, physiotherapists, and we also have over 18,000 nursing student affiliates that we work with and try to support. And from the beginning of COVID-19, I can tell you that we focused on removing the hazards and protecting the safety of our nurses and health professionals, and of course the patients and residents, clients that they care for. Our focus was on prevention and protection. And as a result, we entered into discussions with Ontario government and across a number of tables and ministries in our government here in Ontario to ensure that the proper health and safety measures were in place. And our ongoing fight for proper personal protective equipment, or PPE, as we all, the lingo is pretty clear, everyone I think knows it, is the most important issue that's facing our ONA members, and quite frankly, all healthcare workers in this province. And as you know, we can see from ONA's ads here that you see on the screen, and we've been doing a lot of public ad work and education for them to understand what's happening out there. But you see that nurses and healthcare workers on the front lines are fighting the good fight for their patients, residents, and clients, and indeed for the whole healthcare system. And as I said, when the staff are safe, so are the patients, residents, and clients. It's really pretty simple. And I can't stress enough, at all levels of government, we need to do better. And we need to ensure the system is about protecting frontline workers and therefore the patients, Ontarians, who they are caring for. And I'll talk about some of those things for the future and how we intend to move forward with those. But on the next slide, Julian, if you can move it, from day one of the pandemic, we talked to government and employers and to the Ministry of Labor and the Ministry of Health, and our approach was centered on pushing the government to apply the precautionary principle to their infection prevention and control guidelines for COVID-19. And this, as we all know, is a key lesson that was learned from SARS. And in March, we worked with the government to develop principles regarding PPE in the hospital sector is where we started, which resulted in ONA achieving key amendments to what is now known in Ontario very clearly as Directive Number 5, and that is a directive from their Chief Medical Officer of Health. And on April 10th, Directive 5 was revised to apply to all healthcare workers in hospitals and long-term care homes, and that was our intention to move it right across the sector, right across all whether it be home, communities, and hospitals. But it was on April 10th that we're able to move it to the long-term care homes, and it's core to our approach. The core approach of this Directive 5 is a point of care risk assessment. And this assessment takes place before every patient interaction. It continues to guide the proper use of PPE. And this means that every nurse and healthcare professional to use their clinical, and if it's a nursing judgment, to assess each patient before the interaction. It's a nurse's opinion at what level of PPE is required, including N95 respirators, and when they should have access to that. Neither the hospital managers or employers can unreasonably deny access to appropriate PPE. And in effect, the directive provides that our members with an important tool to exercise their professional rights and to ensure the safe care of their workplaces. And I can tell you our fight for PPE continues. And if you can go to the next slide, please, Julian. So, it was hard for me to believe, and well, I certainly believed it, but to imagine for all of you out there that we actually had to go to the Superior Court in Ontario. And our ground fight there to bring forward the point of care assessment and the value of that in long-term care. So it's important to recognize this sector is dominated by diverse women of color, immigrants, foreign trained nurses, and women with child and elder care responsibilities. Primarily, those are the workers in our long-term care sector. And it's also a sector where for-profit homes, and if you heard Charlene talk about a few minutes ago, have a very prominent place and one main driver, and that's profit. And so in March, after exhausting all our avenues, we had to go to the court in order to get action to protect workers and residents, and we did that. And then on the next slide, Julian, following the court injunction, we ended up at the Central Rights Arbitration and Labor Court, where we took hundreds, actually over 200 nursing homes were in a central rights arbitration with us around the very same thing that we went to the Superior Court. And we were able to manage to get practices changed so that the support would be there for nurses and healthcare workers to have the proper PPE. And I want to acknowledge the brave nurses that put their affidavit evidence forward. It was their stories and the facts around the working conditions that they were experiencing that made the profound effect on the arbitrator in order to be able to move forward. And then we moved into redeployment. And in Ontario, I want to briefly touch on that. And that's where we moved, Julian, to the next slide, please, where we then ended up with redeployment, and where the emergency measures order came into place. With employers, we worked hard for them to work with our health professionals and nurses that they would take volunteers first, that employees would continue to be employees of the sending organization. There were a number of employment principles we wanted to ensure that would be in place before people would be shifted and moved from hospitals to work in long-term care to support the immediate staffing issues and what we believe to be a humanitarian effort now in our long-term care facilities in Ontario. And so building a strong and public healthcare system is where it's all at for us. And on the next slide, Julian, as we turn our minds to the future, I know that we can do this and we can move forward. And we need to work with government, yes, but we need to make sure that we are on the principled side that protects not only the healthcare workers, but the patients that they care for. We need to ramp up the domestic supply of PPE. We have to invest, as I said, follow the money that tells us where the priorities are. And we need to ensure that sectors like public health and long-term care are funded. And we need to phase out or put an iron ring around our the for-profit long-term care homes. I really believe we have a huge problem in our system in Ontario. I know we do, and that the profiteering in long-term care just has to stop, and it has to be out care and respect for the residents that we care for. So we are supporting the call for the inquiry. Our government here in Ontario is calling it a review. I think the word review is weak. I think we need a full public inquiry, and that should happen very quickly after we get through this. I was a SARS nurse, and I can tell you that we were promised it would never happen again, that nurses and healthcare workers were told we would be protected. Again and again, it's been shown that nurses and healthcare workers, when they are safe, so are the people they care for. We can only hope that after this pandemic and the way nurses and healthcare workers have sacrificed and given their absolute all, that it finally will be a wake-up call that all government levels need to hear, and that they will actually act, and it will be a serious attempt or work to move forward on the improvement in our long-term care sector, but our whole healthcare sector overall. So we're in it. We'll stay in it, and we'll work as hard as we can to protect Ontarians, and that is what our focus is today.
Thank you so much, Vicky. If my magicians can put all my speakers' camera on, please, and we'll go to questions. You know, Vicky, I think of the SARS. I didn't live SARS, but H1N1 and Ebola, mostly where we were working at the national level, and the province of Ontario knew what to do. And we told every other province and territories, if the federal government's not going far enough to protect healthcare workers, follow the directive of Ontario. And with COVID-19, we were saying the same thing, because in January, the province of Ontario had exemplary guidance for healthcare workers. And all of a sudden you called me up and said, stop bragging, Ontario. They're changing their mind and they're watering down the guidance. And they were watering down the guidance, not because the evidence changed, because they were all of a sudden worried about a surplus, the supply question.
Issue. Yeah.
So now all my speakers are here. I will go to the chat box and see what kind of questions we have. I'll start at the beginning. We have quite a few. Okay, geez, okay. One question. Why was the Ontario stockpile destroyed? That, Mary, you started to discuss that in your presentation.
You know, that is just an appalling situation. The stockpile was allowed to expire. No funding was set aside to maintain it. And when they realized that it was beginning to expire in 2017, they began to destroy it. You know, if there's a public inquiry, and I think there should be, that should be one area to look at. It was appalling.
Right.
Yeah, because they could have been used by the public right now as surgical masks. Yes, Vicky?
Yeah, I was going to say, we don't know the whole story, and I think we need to find out the whole story. But and the one thing that people have told me who are in this, who do this inventory control as their profession, say, well, for Pete's sake, you can't just put stuff in the storeroom and leave it. You have to cycle it through, and you have to move the stuff. It does have expiry dates on it. And I think there's much more to this story. But I think that inventory control and supply system, supply chain, I think in Ontario, I will say that we've learned a whole lot about what we weren't doing and what we need to do, but supply chain and inventory control, you know, is key to keeping pandemic supply that is going to be able to be used should we need it in the future. And I believe we will need it in the future. We use masks and protective equipment all the time outside of pandemic. It could easily be cycled through. And however that has to happen, it won't be me figuring it out, but those experts should be able to figure that out.
Okay, thank you. One administrative questions, the PowerPoint and also the taping of the session will be made available. It'll be on our website, YouTube, and Facebook. but also every participant will get a summary of the presentation that CFNU will be doing following this. And we verify with our experts, of course. And that also goes to every member of parliament and senators, because this topic is important, and we want them, if they weren't able to participate, to have a summary to base their next questions in the House. So the recording. Do we need a royal commission to look at long-term care in Canada? Let's say I'll start with Samir and then jump to Charlene.
You know, I think the challenge here is that, as I said, long-term care, and, you know, as we talk about home care, but also care in nursing homes and retirement homes, all of this is outside the Canada Health Act. So it's been left at the discretion of the provinces and territories and how they want to organize it, how they want to fund it, what they even want to cover. So I think, you know, we've had the Prime Minister, we've had the Minister of Health federally, we've had several premiers, and now ministers accordingly say the system is broken, it needs to be fixed. And again, you know, we've heard about the idea of a review, not an inquiry, a commission or whatever. You know, the key is, I think we all agree that we need to figure out what went wrong. I think we already have a lot of ideas, but, you know, back to Vicky's point and others, when we're told that this will never happen again, I mean, as a geriatrician, I think about the thousands of residents, but also their care workers who died to date. That's one death is too many. All these deaths is a travesty. We need to think of this as a nation, because we may need to bring this into the Canada Health Act. But it's not just about bringing something to the act, it's how do you actually make sure that every province and territory is doing things as we can, and tying it back to what Linda and Vicky were saying at the beginning. We were talking about, is Ontario the leader? That in this case, BC, in my view, has been the leader in terms of taking more decisive actions when it specifically comes to long-term care. And that's why only about 10% of BC homes ever appeared an outbreak. In fact, they're actually doing much better now, whereas Ontario had the dubious distinction today where 25% of its homes are now an outbreak, and we've had the most number of deaths amongst nurses and personal support workers in these settings. So we need to have a national conversation, and we need to have action in every province and territory as well.
Thank you. Charlene?
Do we need an inquiry? Absolutely, and we need that inquiry now. In Ontario, we're up to 1,700 deaths. As we mentioned, there was 44 at SARS. Today, the Premier came out and said that he finally agrees to having other organizations manage these long-term care homes that have got these horrific outbreaks and numbers and deaths in them. We asked for that 4 weeks ago, and the argument was that he didn't have the authority to do that. Well, he found that authority today. And why wait for the inquiry? Do it now. It cannot be a review, because we've reviewed the problems in long-term care for 2 decades already. I think people know what the problem is. What they need to do is get an outside person so that they can't put their thumbs on the scales of what the results are, and do a proper review and an inquiry of not only what went wrong, but like Dr. Samir said, that lots went right in other provinces. We have to learn from that. So an inquiry is needed now, not when this is over with, because what is the right number? 2,700 instead of 1,700? We need to look at it now and right across the country, do a federal one and provincial as well.
Thank you. And now I've been very generous. I've been very generous with my panelists. We'll try to keep our answers quite short so we can answer some of the questions. My next question is, how long do you think this will last? Are we talking 18 months plus? Mario, Samir?
I can start. I mean, right now, we were hoping that the quickest we would ever hope for a vaccine is about 18 months. I mean, some people say 12, but we've never actually achieved that. And the reality is we may not find a vaccine, and COVID-19 might be here to stay with us for the rest of our lives. I hate to be the bearer of what the science is telling us, but that could be it. So that's what we know right now.
I think that we should hope for the best, but prepare for the worst. And the worst might be continuing cycles, continuing demands for public, for PPE, continuing demands on all of our systems. So I think we should really prepare for the worst. And just to reflect on the previous question, there are really two types of inquiries that we could have. One is a longer one like we had in SARS, which took 3 to 4 years. There was also during SARS a Naylor inquiry, which was a quick action in a few months that identified critical issues and how to fix them. So I think we need some immediate action, but also that shouldn't preclude a longer term inquiry as we had during SARS.
Yeah, exactly. Thank you. My next question I'll refer to Charlene. The first one is, what's the proportion of Ontario's long-term care residents for-profit versus public? Do you know?
Yeah, there's much more for-profit than there are not-for-profit in the industry. And that's probably why you're seeing the large numbers in the not-for-profit as well. But definitely, in the numbers that we're seeing, it's close to about a 70% difference increase in for-profits than not-for-profits.
And right now in Ontario, it's 60% of the homes are for-profit, 24% are not-for-profit, and 16% are municipally run.
Mm-hmm.
Thank you. And all of this will be part of our summary too. Vicky, the next question is, should our long-term care sector be part of our public system, for example, the Canada Health Act?
Well, certainly, I think what we see before us now, and it is all about what, I truly believe how we act and what we do now, we will be judged by that in the future. And I think that we owe it, to the citizens of this province and our country to be able to provide the care that people deserve and should have. And we should have it inside. It should be, it is birth to death. That should be the care that we provide citizens of this country and of Ontario. And when you think about the amount of, someone said to me, well, we can't afford that. And I said, well, just think about how much money is being spent now out of people's personal pockets plus the funding that's provided. It is about, yes, following the money, but we should do that. We absolutely should include it inside and care for the citizens of this country. And other jurisdictions have excellent experience with this that we can learn from. It isn't about reinventing the wheel.
While you have the mic, Vicky, a lot of questions. There's a lot of thank you, solidarity messages, and others. But one is, what's the difference between a surgical mask and an N95?
Well, certainly the basic sort of 101, it's the filtration. It is about the filtration of the particles that can come through the mask. And the N95s are fit tested, which means that people have to be tested to ensure that they have the proper seal so that there is proper respiratory protection. But the other thing about this, there are higher levels of respiratory protection. And it seems like, yes, we talk about N95s, we're kind of on the spin cycle of N95s, but it isn't all about N95s. There are other levels of protection that are higher than that. And when you look at other jurisdictions and what they're doing, and it is about higher level of protection. Minimum protections are N95s, and the full suit saw in the scenario had, and no healthcare workers were infected. So what does that tell us? The science is, there's science on both sides of this. I absolutely know that, but the reality is there's more and more every day that's coming out around the particles and the transmission and how it can become borne by air. And that's what we're talking about here. N95s, minimum protection we would wish, but it's not. We don't have that here in Ontario, but we started that. We started with N95 protection, erring on the side of caution. And then there was the U-turn, and that's when things started, when we started to get into trouble, I believe.
Yeah, it'll be quite interesting to read all these reports. But also, one of the question was, do we know exactly what the healthcare workers that have died because of COVID-19, what they were wearing? And we don't know. We can estimate in long-term care that they weren't wearing it, but those are important questions. My next question is on
the investigations.
Also.
I was just going to say, Linda, the investigations of that are critical. And this is certainly some of the investigation pieces that we are working on and will pursue. as well, and the availability of PPE. That's why we had to go to court, to the Superior Court, for Pete's sake, and then into this huge rights arbitration to get what was the right thing for protecting workers and the residents and Ontarians. It's just the logic of it all is just such a mystery. It's just so difficult.
I have so many more questions. What we will do there, I'll shut this. What we will do is those answers that we do have from CFNU Research, SEIU, Dr. Sinha, and Mario, we'll answer the questions, and when we send you the report, questions from testing, question from diversity, how is it impacting different race, the human rights issue, the questions were really coming on, and a lot of thank yous for the four of you and for all of us to continue our work. What I have to say is the Canadian Labour Congress just last Friday passed a strong motion that we start working on including long-term care, home care, within the principle of the Canada Health Act. And why we did that, it was to protect the vulnerable, because the vulnerable are, yes, our seniors, but also the vulnerables are the workers that are working with these seniors and other vulnerable population. So we will all be together on this. So again, a big thank you for all the participants. I'm proud to say we had participants from coast to coast to coast. I can't wait to see the final numbers, and I'll send it to our experts here. We at CFNU, SEIU, ONA, and others will continue our advocacy role on this. It is so important. I thank all the MPs, the senators that are online, and I know it's hard for all of you, but a webinar, you couldn't speak. So I do thank you for your patience. And for those who are on the ESSA and the UMA committee, I thank you for your work, because it is so hard to do our work when we're people, eh? And we like to talk and to touch and to listen. And now we have to do this through this new world. So I wish all of you stay safe, wash your hands, use the 2-meter distance, because that's what will protect us. And if you don't listen to the nurse, listen to the doctor. Do you agree, Samir?
I always listen to the nurse first, but I just repeat what they say. You know that. Happy Nurse Week as well.
Thank you. So I'll hang up. Virtual hug to everyone again. Stay safe. And thank you, Vicky, Mario, Charlene, and Samir. Bye-bye, everyone.
Thank you.
Bye-bye.
Stay safe,
Thank you.
everyone.
Thanks, Linda.